pharmacist Karim to give us a 30-minute presentation on handling dry eye disease and what we need to know as pharmacists. Pharmacist Karim Adeniji, the floor is open.
Okay, good evening, everybody. I stand on existing protocol.
Good evening, sir.
Right. Can you hear me? Can everybody hear me well?
Yes, but make it a bit louder.
A bit louder. Okay.
Yeah.
Okay, how about now? I'll just try and amplify
Yeah.
my voice a bit more.
We can, but is everyone hearing him clearly, loud and clearly? Hello?
Not very loud.
Okay, and try to increase your volume. It's not very loud.
Or maybe on the let me check this settings.
Try to adjust the volume a little bit.
Okay, is it better now in any way?
It's improving, yeah.
It's improving. I'll just try and speak louder and hope everybody can follow. Okay, right. So I'll just share my slide now. If this works well. All right, can everybody see the slides very well? Okay. Can everyone see the slides?
Yes, we can see your slide.
Yes, I can see from here.
Okay, thank you very much.
Yes, we can see your slide. It's clear.
So,
it's showing.
Okay, so we're discussing handling dry eye disease, the role of pharmacists. Dry eye disease, it's a common disease, and it's something we encounter very often. And this presentation is just to show what we need to know, how we need to sequester the patients, and the kind of treatment we can administer. My name is Karim Adeniji. I'm part of the Ophthalmology Pharmacists of Nigeria, and I'm also a biomedical scientist. So, dry eye. A definition has been given for dry eye by T-Force Dews, which is the Tear Film and Ocular Surface Society Dry Eye Workshop. It's a think tank of professionals in optometry, ophthalmology, and eye care generally. So they've defined dry eye as a multifactorial condition of the ocular surface marked by tear film instability, tear film hyperosmolarity, inflammation of the surface of the eye, and they've added another dimension, which is abnormalities in the neurosensory functions. So we're going to touch on all four factors, but mainly focusing on tear film instability because that's pretty much what we can handle and in the pharmacy setting, and those are the symptoms that will be exhibited for us to handle. So the T-Force Deals group, they use a graph to represent the continual process of the disease. There are causative factors, which are either intrinsic or extrinsic. And then you have the key factors in the loop, vicious cycle, we call it, which perpetuates the disease, which is the tear film instability, tear film hyperosmolarity, and inflammation of the ocular surface. So this is the graphical representation of dry eye disease, essentially. It starts with the causative factors, which causes tear film instability. So that's step one. A lot of the treatment is geared towards tear film instability, and that prevents it going to the next step of hyperosmolarity or ocular surface inflammation. So those are the three main etiological factors of dry eye. And you can treat all three, but most treatments now focus on just the first one, which is tear film instability. T-Force dews also classified dry eye into two primary types. So there's the aqueous tear deficient dry eye disease and evaporative dry eye disease. There's subtle differences between the two. So the tear deficient, just as it states, is the inability to produce tear film, while the evaporative dry eye disease is due to loss of the top layer. And we'll also go through all the layers or the phases of tear film shortly. It's key to know that dry eye doesn't cause blindness, but the discomfort that it causes can be very debilitating, both physical and social. In terms of epidemiology, dry eye is very prevalent. Many studies have recorded vast differences from 5 to 50% of adults globally. Few studies have been done in Nigeria. I could find about 2 or 3, and most of them have a prevalence of 27 to 33%. So the tear film is made up of 3 layers: the mucin layer, the aqueous layer, and the lipid layer, also known as phases of tear film. The meibomian gland, which is on the eyelids, produces the lipid layer, which is the top layer. The aqueous component is produced by lacrimal glands, and the mucin is produced by goblets. So the aqueous layer is in between, and the mucin is directly on top of the corneal surface. Tear film provides optical surface that enables clearing of debris from the surface of the eye. It prevents infections. It also suppresses inflammation, and it promotes healing. Tear film itself, it's quite complex. That's why sometimes the term artificial tears is very, very misleading. I don't think it can be recreated really. It's composed of over 1,800 different kind of electrolytes and solutes. So when we are talking about dry eye disease, really, we are talking about loss of homeostasis of the tear film. And we'll go through some other examples of how you can lose this homeostasis. So this is an image of the tear film with the 3 layers. You have the ocular surface, and you have the mucin on top, which is composed of glucosaminoglycans, mucin itself. You have the aqueous layer that has different kinds of salts, and the lipid layer, which protects the aqueous layer from evaporation. So homeostasis in the tear film is maintained by what we call the lacrimal functional unit, which is the eyeball and the nerves that innervate the eyeball and synthesize production of tear film from all the goblets, the meibomian glands, and the lacrimal gland, like I mentioned earlier. So any compromise in function of the lacrimal function unit would lead to tear film dysfunction and loss of homeostasis. Injury can lead to that. Disease state can lead to that. Aging can lead to that. And you also have maybe some neurological conditions like trigeminal neuralgia, Bell's palsy, and some other nerve conditions that can lead to a dysfunction in tear film production. So this is just an image of the lacrimal function unit. We have or the glands I've mentioned, the goblet cells, lacrimal gland, and you have them all going towards the trigeminal ganglion, and that passes back information through sensory nerves, parasympathetic and sympathetic. So pathogenesis of dry eye itself is quite complex and not fully understood. But the key focus areas now are an immune response to external stressors. So you have air pollutants, microbes that get on the corneal surface that leads to free radical production, reactive oxygen species, leading to ocular damage. And once the lipid layer is affected and the aqueous layer starts to evaporate, the eyelids start to rub on the surface, and that can lead to injury on the corneal surface, and you have minor corneal ulcers due to that. This is just going further on the innate immune response to any ocular surface issue. It leads to acute inflammation, upregulation of protein kinases. leading to inflammatory mediators being released as well, such as cytokines, matrix metalloproteinases, tumor necrosis factors, and this just perpetuates the cycle of dry eye disease. In terms of diagnosis of dry eye disease, this probably will be done at the clinic, eye clinic. It's not something we can really perform in the pharmacy. The most common one is Schema eye test, then slit lamp examination with staining, tear function index, tear breakup time, tear osmolarity, and some other ones. There's some also physical examinations also that can be carried out, such as late margin diseases, people that have blinking abnormalities, because blinking itself helps to produce all the components of tear film. Each time you blink, the eyelids squeeze together and the lipid is produced from the meibomian gland. So if you have a blinking issue, you can't blink properly. This can be dry eye disease. Okay, so this is just the Schema eye test, and this is what it looks like. So the strip itself is inserted into subconjunctival sac, and you can see the strip is already wetting. So the distance the wetness travels is measured. You can see it's a very simple test to do. It's a very cheap test as well. This test strip actually has marks on it to
Me, I want to talk. I'll put it.
5 centimeters. Other ones are calibrated for you to have a more accurate diagnosis. So the role of the pharmacists in management and treatment of dry eye. Pharmacists need to be aware of the conditions that lead to dry eye. So the initial focus while you are speaking to the patient and trying to get some history is to understand the lifestyle. Do they wear contact lenses? What kind of job do they do? Is it an outdoor job, and would it require them to have protective glasses, for instance, that will prevent from environmental factors? What is their medication history? Some antihistamines can lead to dry eye. Hormone replacement therapy can also lead to dry eye. Tricyclic antidepressants, selective serotonin receptor inhibitors, and also preservatives in dry eye can lead to preservatives in eye drops rather can lead to dry eye. So you must be really careful in terms of diagnosis, but when you have more information, you can really know what's going on. You should also reassure the patient that dry eye is not life-threatening and almost nearly leads to any loss of vision. But then with the burning and intense pain, sometimes people really feel it's worse than it is. Also, you should be aware of glaucoma and the relationship with ocular surface diseases. Reason being, glaucoma patients are normally on more than 1 or 2 eye drops which are preserved, and like I said before, preservatives itself does cause dry eye, especially benzalkonium chloride, which is in many eye drops. Autoimmune diseases also cause dry eye, like Sjogren's syndrome, leads to dry mouth. You can ask those questions there, dry mouth, and then you can now link it to what could possibly be happening. Other inflammatory conditions like rosacea, trigeminal neuralgia, like I said, any facial nerve dysfunction can lead to dry eye. Then surgery, previous surgery too has been associated with dry eye. This high level of cataract surgery, which is already well known anyway, and they will be prescribed artificial tears after the surgery. And then diabetes as well. Diabetes has been known to affect water homeostasis, high dehydration or thirst, and that can come from diabetes. So you just want to know what kind of conditions the patients might be suffering from. The key symptoms for dry eye disease is, maybe mild, severe ocular discomfort, ocular dryness, itching, redness, pain. The pain from dry eyes is like a burning pain, like fire kind of pain, heat. There might be some photophobia, feeling like there's a sandy feeling, gritty feeling in the eye when they rub it, when they blink, because The eyelids are rubbing on the ocular surface and it's giving up that sensation. You have stinging sensation, eye fatigue. The ocular discomfort, like as we mentioned, is sometimes used to classify the severity. And you can now start asking how often, is it every week? Is it every day? Is it, hourly? Or is it continuous? And you can use that to gauge the severity level. One key classical symptom of dry eye is eye watering or tearing. So the eyes will be tearing uncontrollably, which is a bit ironic. And the clients sometimes are, a bit confused. You say I have dry eye, but my eyes are watering. How do I reconcile it? But that's a classical symptom of dry eye because it is an overcompensation by the body trying to mitigate the situation. Other conditions such as blepharitis and incomplete blinking and lid closure problems, like I mentioned earlier, any lid issues could definitely lead to dry eye. Other risk factors to know about is smoking and alcohol. Like we always say, if you can remove smoking, alcohol, obesity, maybe 90% of the risk is gone. Menopause, females are more prone to dry eye, pregnancy, and vitamin A deficiency. As we probably all know, artificial tears is the first line treatment for dry eyes, and that is one group of drug that we can prescribe freely that has low potential for harm. So if you are doubting if it's dry eye or not, you can still prescribe artificial tears and watch for a week or two, and if it's not improving, then you can refer. They provide remarkable palliative and symptomatic relief in all stages of dry eye, from mild to moderate to severe. They are normally topical eye formulations. There are many types of artificial tears on the market. So choosing the appropriate one is essential, but sometimes any could be chosen just to start, and then you see how the condition develops. Like I said, we saw preservatives in eye drops can also lead to dry eye. So when possible, try and avoid artificial tears with preservatives. I know it might not be possible in all situations due to price and other considerations, but when you can, offer preservative-free to patients. Products that don't contain preservatives are normally single-dose units, but now there are multi-dose bottles of preservative-free available. So, for instance, if patients are going to be using 4 to 6 applications per day, then preservative-free is highly recommended. So these are the common ingredients we find in artificial tears. We have the alcohol demulcents. So we have cellulose derivatives, gelatin, dextran, polyols, and polymers. The two main cellulose derivatives that are on the market are carboxymethylcellulose, also known as camellose, high molecular weight, and you can see with the carboxymethyl group, it binds to water very well, and that increases the viscosity on the eye surface. Hydroxypropyl methylcellulose as well, hypromellose is another example. It's less viscous than camellose, is smaller in size. Sodium hyaluronate is a more complex viscosity enhancing agent. It's a bulky glucose aminoglycan. It has a greater water retaining property and less resistance to blinking, so more viscoelastic. Use of gels and ointment are normally for nighttime, and the reason for this is they're very occlusive and they lead to blurring, so might affect vision during the day. And they have a long retention time as well, so they can be used at night, and they will be on the eye surface for up to 6 hours. Where possible, you can have combination products, especially if you suspect severe dry eye. A combination of products might be useful. Yeah, this is just the polyol example. So we have polypropylene glycol, polyethylene glycol, glycerin. Note cases of moderate to severe dry eye may require specialist advice. Like I said, if you have tried artificial tears and there doesn't seem to be any improvement, then you can refer to an eye doctor. So this is just a table showing the common active ingredients in dry eye medications. You have camelos and hypomelos, which are mucoadhesive water retention. You have levocarnitine, trehalose, which are osmoprotectants. They help to retain water by osmotic effects. And hyaluronic acid, like I said, mucomimetic, water retention. And then you have the oils, castor oil, mineral oil, flaxseed oil. This sits on the surface of the tear film and they mimic the lipid layer of the tear film, which prevents evaporation. So this is used more for evaporative dry eye. This is a table also showing how different ingredients perform against dry eye. So the key 5 factors that are looked at for dry eye in terms of their effects is how well do they perform on tear film stabilization, corneal blinding, cytoprotective properties, secretion of mucin, and reduce inflammation. You can see all of them do tear film stabilization, which is step 1 of the cycle that we started talking about. So once you can break that chain, really, it doesn't move on to the next step of tear film hyperosmolarity or inflamed eye surface. You can see hyaluronic acid does more than tear film stabilization. Also binds to the cornea because hyaluronic acid is natural receptors. And other things like trehalose, and you have drugs for inflammation only, like your steroids, cyclosporin, and the likes. So this is just a note of caution. Products containing steroids should never be prescribed under any condition by pharmacists. Always prescribe steroids on prescription. And the reason for that is every red eye, which you would see with dry eye, needs to be diagnosed first because it could be a bacterial infection, a viral infection, or fungal infection. So steroids sometimes can aggravate these infections and lead to ulceration of the cornea, which can actually be quite serious, can lead to vision loss and even loss of the eye. Steroids also increase intraocular pressure. So if you have a glaucoma patient as well, you can see how this would lead to more issues. And sometimes it can move people that are predisposed to glaucoma into active chronic glaucoma as well. Steroids can also lead to what we call steroid cataract, which is a subcapsular cataract. And steroids also lead to thinning of the sclera and the cornea. So we need to really be cautious when administering steroids. Always make sure there's a prescription. And even when there's a prescription, ask some questions to ensure they are needed. So just some general tips to take away on general eye health. Keep hydrated. It's a counseling point you can give to the patients. Don't smoke, don't drink, eat a versatile and colorful diet. The more colorful it is, the better, because that tends to mean it has carotenoids in them, which are in the macula of the eye. You can use nutritional supplements containing lutein, zeaxanthin, omega-3. It's also good for dry eye, especially the lipid layer. Foods rich in vitamin A, C, E, and D, zinc, selenium. Also, going outside and remaining physically active is good, helps with water homeostasis. And then abide by the 20-20-20 rule, because we are all on devices a lot more, and that affects our blinking. The more you stay at devices, you blink less. So when you're at your desk working, every 20 minutes, try and look at an object 20 feet away for 20 seconds. That helps you focus the eye muscles and helps with your blinking. Thank you very much. Those are my references. I will take questions.
Okay, thank you very much, Pharmacist Karim, for that brief and precise, in a very precise presentation, straight to the point. So we want to really appreciate you for being part of us. We thank you for, taking us through dry eye disease, what it is, and then the pathophysiology and how we can handle it, and then the things we need to know with respect to its management.
Yes.
So before I talk further, I would like to, ask if anyone has any question or contribution to make or anything to be cleared. The floor is open. Signify by a raise of hand and I will call on you. Thank you. Okay, someone is raising hand here. I mean, what's the name? Okay, 2 hands are up. Sorry, I'm trying to get the name. Okay, I'll call on Bisola, Pharmacist Bisola, to ask her question.
Thank you very much. Very great, really succinct presentation. Thank you very much, Pharmacist Karim. I guess some observation more than anything else, because you mentioned a few conditions I was even aware could lead or cause or exacerbate dryness in the eye, like diabetes. I'm much more aware of sort of diabetic retinopathy. So, of course, that would suggest that managing all the risk factors beyond the cause or leading to the eye dry eyes is really important as well. My question actually is to do with preservatives in eye drops. In that, where is their place these days? Because of course, both are available on the market, but we recognize that preservative-free products are the best option where available. But I'm conscious of the fact that products that contain preservatives are still being used. And therefore, perhaps you can shed some light as to where is their place and should they really still be available or should be last resort?
Okay. Thank you very much for that question, Mrs. Bisola. Yeah, and thank you for your observation on risk factors. More associations are being made with dry eye, always more research is being done. For the question on preservative-free, ideally, in an ideal world, for dry eye anyway, it should be first option, because it's ironic if you give a preserved eye drop for dry eye where the preservative might be the cause. At least, let's say if the preservative is benzalkonium chloride, which is the worst offender. I think a lot of eye drops now are moving away from benzalkonium chloride and using less ocular toxic preservatives like purite, which sort of like breaks down into another breakdown product when it touches the eye surface. But if you can avoid preservatives totally, especially when it's severe, I think that would be the best option. There's a price issue, and I understand, that has to be taken into consideration. Preservative-free is normally more expensive than preserved. But preservative-free has its benefits, like I already said, and they are actually very available, even though this may be some kind of conflict. There are many products, maybe I won't mention the name. There are ones that are multi-dose even now, which means they are in a multi-dose bottle. They are not in your single minims anymore. And you can use them a lot of the time for up to 3 months, up to 6 months, because they don't have any preservative. Essentially, they work by preventing air from going back into the bottle after the drops come out. And any marginal air that's going to go back is being filtered through a special membrane. So yes, they are available. In Nigeria, they are available. Anyone that needs can reach out to me later, and I'll let them know how they can get over them, both the single dose and the multi-dose types. Thank you. I hope I've answered the question.
Yes.
Okay, yeah. I also want to add a little to what he has explained everything. But like he said, most people that have glaucoma eye conditions, they're on chronic eye drop usage,
Yeah.
anti-glaucoma agents, and many of them, like you said, they have a back, and the back is a preservative in eye preparations that can also have ocular surface effect. And then the use of back, usually causes what you call ocular surface disorders like dry eye disease, as an example. So that glaucoma drugs are usually placed on artificial tears, tear substitutes like Melo tears, any of the tear substitutes to help manage the effect of the back, the drug, the back in the anti glaucoma drugs, because it leads to ocular surface. Why, like you said, the drops, and most times in Nigeria, they're not usually very available, and if you see them, they're very expensive, very expensive. If you check out ophthalmics, the ones that have a back, they're usually affordable, they're usually cheaper, but the ones without back are usually very expensive. So that's one of, like he said, if you want to get preservative-free eye drops, you can reach out to him. And then, for example, an artificial tear called micro drop, is usually known to be preservative-free. So I think it's not so common, but then if someone looks deeper, so one can find it. It's very free. When issues of that occur, and then you get an artificial tear that contains back, it will worsen the whole scenario. But when you use a preservative eye drop like Pharmacist Karim, has enlightened us, it goes a long way in giving faster relief, with respect to that. Okay.
Yeah, that's true. I think general practice now is to just prescribe artificial tears routinely with glaucoma drugs. That's what's being done now.
Okay. Then Pharmacist Odetola Adeyo, you can ask your question and make your contribution. Sorry, the person that sorry, I wouldn't know if your question was answered. Pharmacist Bisola, was he?
Yes, very much so. Thank you very much for the time.
Okay. Pharmacist
Good evening, Fam. Thank you very much for the presentation. Please, can you hear me?
Yes.
Okay. So I want to ask a question. What's your opinion on the role of antihistamine? Because they actually have the side effect of dry eyes. So if a patient comes with, how do we distinguish an itchy eye that is from an allergy and that from a dry eyes? And when we give an antihistamine that causes a side effect of a dry eye, do we increase the risk of, causing patients to have dry eye? And if we do that, is it okay to give an antihistamine and they just give an artificial tear as a backup?
Okay. That's a question with AI, BII, BI, BI, BII. Okay. Right. Role of antihistamines. I think I mentioned it earlier in the presentation. Antihistamines actually can cause dry eye due to parasympathetic effects. Way to differentiate between itchy eye and dry eye is, yes, dry eye can be itchy, but with dry eye, there are two classical symptoms, which is tearing and burning. Okay. Or let me say three: tearing, burning, and feeling of grittiness, like feeling like there's sand in the eye. Those are three symptoms that can distinguish dry eye from just an itchy eye. If it's just itchy, they are looking at giving something topical anyway. I don't know what you meant by giving antihistamine. Do you mean giving it orally?
Yeah, orally, and also as an eye drop, like antazoline now.
And normally, general practice, anything to do with the eye is always topical because blood supply to the eye is poor and there's none anyway to the cornea. So eye drops, antihistamine eye drops would be fine if you are giving it for itchy eye. Or mast cell stabilizer, for instance, sodium chromoglycate will be fine. But you need to distinguish between the two. If you are struggling to distinguish between the two, refer. That is always safer. Eye issues can be quite technical sometimes. For instance, redness in the eye can be due to 10 different types of conditions. So sometimes you cannot necessarily distinguish unless you have those classical symptoms that I mentioned. So you said, what is the role of antihistamine? Like I said, it's topical antihistamines only in this situation we are talking about, anything to do with the eye.
Pharmacist Karen, please, can you increase your volume a little?
Okay. I hope you heard my answer so far.
Yes.
Okay.
Yes.
So I'll move closer. Sorry, I'm so close to the camera. So yes, I think I've summarized really. So any antihistamine should be topical application, eye drop. So no oral, because it's probably not going to get to where it's needed. Distinguish dry eye from itchy eye with 3 classical symptoms, which is burning in the eye, like fire kind of burning, gritty feeling like there's sand in the eye, and tearing. So those 3 classical symptoms, once they are present, that's dry eye, and go ahead and give artificial tears.
Okay. Thank you.
I hope he has answered your question.
Yes. Thank you very much.
Someone asked a question. He said in the chat, please, sir, can you explain better why steroid-containing products should not be used in dry eye problem? Mrs. Karim?
Okay.
Did you get the question?
I got the question. Yes, I think this was one of the few slides to the end. So I'm not saying steroids cannot be used at all, because if you joined earlier on, you would have seen the vicious cycle, which has inflammation as one of the factors that perpetuates the cycle of dry eye. So when there's inflammation, steroids are an option. But what I said is we are not to prescribe steroids. So steroids should only be dispensed with a prescription, because red eye needs to be diagnosed. Any kind of red eye needs to be diagnosed first before applying steroids. So if you encounter anyone with red eye for whatever reason, avoid giving steroids. I think that's the message I was trying to pass. If you are to give steroids, there must be a prescription, because then the eye surface has been examined, and it has been examined for infections such as viruses, fungal infection, and bacteria. Herpes virus, most especially. If you administer steroid when there's herpes virus, it can lead to ulceration of the cornea, which is the surface of the eye, and it can lead to eye loss of vision, and eye loss. So, I mean, it's quite serious. That's why I say pharmacists should avoid giving steroids without a prescription. So yes, steroids are given in dry eye, but that would come from the eye doctor in that sense. I think for us, artificial tears does an amazing job. Like I said, it tackles the first step, which is tear film stabilization. A lot of them work by bulking up the aqueous layer, and with that, you are not having rubbing of the eyelid against the surface. And then if there's any minor cornea ulcer, presently it gives the eye time to heal. So I hope that answers the question.
Okay, thanks so much, Karim. In order to add to what you've explained, I've been in a community pharmacy where I saw some patients come in with some prescriptions of steroid, so that they were asked to come and get some steroid for their eye, conditions. So when on further questioning, they will tell you that they went to one pharmacy and the pharmacist asked them to come and buy the drug, different stories here and there. So, but when I talked with them more closely, I found out that, because they had red eyes, and the pharmacist or whoever that prescribed wrote the steroid for the patient. I've seen that on different occasions in my practice. So, and then I will tell the patient that you may not need this eye drop. Like you said, steroids are better prescribed, by an ophthalmologist, especially when the eye has been looked into with the aid of an equipment. The slit lamp, the eye is something you can just see on the outside, but there could be so much that that goes on in the inside that you cannot even see. So even an ophthalmologist cannot even diagnose well if he doesn't use his equipment to see at the back of the eye, or to look into the eye well to see what's going on. So once you have a red eye, in a patient, you don't give steroids. Number one, that patient might have issues with glaucoma, and then when you give steroid, it can lead to a corneal ulceration, and it can even raise to increase increase IOP, intraocular pressure, which can also lead to further glaucoma risk. So once you see a red eye, if you cannot differentiate, please just refer. It's very important. It's not something we can just feel like and then give as we want. It's very important. Then, secondly, you have what you call steroid-induced glaucoma. Whenever steroids are prescribed, the patient has to be monitored very closely. And in ocular surface disease, which a dry eye is an example of it. One steroid is usually given basically when the dry eye disease has become very severe. You have ocular inflammation. You now prescribe steroid. Otherwise, at the initial time, it's better to remove the triggers. For example, if someone is in a smoky environment, it can worsen dry eye disease. So if the smoke, the trigger is removed, or the person goes away from that environment, the person feels better. If the AC has been on for a very long time, it can also lead to a dry eye. It can worsen a dry eye condition, or the fan has been blowing for a very long time. The person can have a worsened dry eye condition. That's why sometimes when you see someone in an AC place, or who has been in the AC for a very long time, the person has a way of tearing. If you blink, the person tears. So once you can remove all these triggers, or things that can worsen dry eye disease, and at rest, the patient is still tearing, is still having issues, still having an itchy feeling in the eye, is still having a feeling of sand in the eye, gritty sensation in the eye, or is still having this redness, even at rest, even when these other things have been removed, then the patient has that means the dry eye disease has gone to a higher level, or a more severe level. Then that patient has to be referred, or that's when you talk of not giving steroid. Otherwise, the first two stages of dry eye, you don't give steroid, you just manage and then try to now treat. If you have an infection or an allergy, you treat, because otherwise those things will worsen the ocular surface discomfort, and then can also lead to dry eye disease. So that's about sorry that is. Sorry, any other question or confusion? Then I want to suggest that like I said, once someone presents with a red eye, itchy eye, burning sensation of the eye, gritty feeling in the eye, or tearing of the eyes, just suspect the dry eye disease. First of all, dry eye disease is multifactorial. You have to ask many questions. The person could have been on steroids. The person could have been maybe, let's say, during winter, has been exposed to the has been outdoors for a very long time. The person could have, so you have to look at the local cause of the dry eye disease and then deal with that without drugs. But if the things, if after it's been done and it's still not there, it's still happening, or the person is still feeling worse or not being helped, you can now introduce artificial tears. Artificial tears is the commonest, help or the drug you can use to help or manage dry eye disease. And there are different types from solutions to gels to emulsions to ointments. There are different types that one can use to manage it properly. Then, so for now, let me not talk too much. Other people can contribute. Other people in ophthalmology or any other person can bring up a contribution
There's
question.
some questions in the chat.
Okay.
There's some questions in the chat. So I'll
Okay.
just
Okay.
somebody said, is dry eye hereditary? To the best of my knowledge, I'm not aware of any link, any genetic link.
Okay.
And is it age related? Yes, it is age related.
Yes. Yes.
As most bodily processes slow down with age, you'd see it's more an elderly person's disease. So yes, it is age related. It's more prevalent in older people. Please explain why steroids containing should not be. Okay, I think I explained that one already.
Answered.
Please does adding yeast powder or yeast tablet to food have any complementary effect in curing dry eye problem? Well, to this I'll say no directly, because yeast itself it's more in terms of improving gut health. Saccharomyces is the general group name. But you find like some of the products we sell, they're actually fortified with vitamins, so they might have vitamin A and other things added to it. So yes, if that's the case, yes, vitamin A is good for dry eye, as I alluded to in the presentation. Vitamin A deficiency is one of the risk factors for dry eye. Okay, thank you very much.
Thank you, Mrs. Karim.
Okay.
Vitamin omega-3 fatty acids, omega-3 supplements, they are very good. They are very good in managing dry eye conditions. So you can recommend it for your clients, your patients. It's very good in managing dry eye conditions.
Somebody also said, does this condition occur in children? If yes, does it follow the same treatment measure? Yes. If it occurs in a child, artificial tears, they are very safe. They can be used from as low as 2 years and above.
Yes. In order to add to what you have said, it cannot occur in children, at any age. But most times when it occurs in children, it's usually congenital, and that condition is called alacrima. Once there's a fault or an error in the way the lacrimal gland works, or the way it works, it can affect a child. For example, if you see a child crying, the child is really crying, but there are no tears, so that child should be monitored very closely. Usually when a child cries, you should see some tears. So when a child is crying and you hardly see tears, or you have some eyelid deformities in a child, that child should be monitored closely, because that child might have a congenital, eye issue, lacrimal gland issue, and then that could lead to dry eyes in children. So ordinarily is not common, but it can happen to a child, especially a child that stays outdoors, especially people that are in the Western world, like that have a winter, have autumn, have spring. Then during winter, children can have that dry eye disease, but it's not common down here in Africa. But if you see it in Africa, if you see it in any child, it's usually a congenital disease, and it has to be managed well. Okay. Do we have more questions? More contribution.
Are there ways? There's a question in the chat. Are there ways of preventing dry eye? And are there other eye conditions that can cause dry eye? For example, astigmatism. Ways of preventing dry eye, I think we've mentioned them in a roundabout kind of way. Try and protect your eyes from the elements, from extreme weather, from pollutants. So if you are doing a very sort of like dangerous job, wear protective goggles. I won't say avoid AC, but be in a temperature controlled room. Diet, yes, diet is one way. Fatty fish, like they said, that has a lot of omega-3, a lot of fruits and vegetables that have carotenoids in them. Being active as well helps with homeostasis of the tear film. So I think those are general ways of preventing dry eye. Can it cause astigmatism? Possibly, you can have some corrective and refractive due to the paucity of the tear film, but direct link, I'm not too sure. But theoretically, it's possible. Not the dry, not the astigmatism causing the dry eye, but the dry eye itself. It might lead to some corrective refractive issues, but not a strong link. Let me say.
Okay, there are also eye glasses or eyewears that also help to preserve keep moisture in the eye.
Yes.
One can also get such a eye goggles and also use them as well to help they help to preserve moisture around the eyes. That's another way of helping to prevent the dry eye disease as well. Then astigmatism, like you said, astigmatism, will not cause dry eyes, but dry eyes, if it's not well managed, can also lead to that indirectly. It can lead to what you call refractive errors, and which astigmatism can be diagnosed. But then that's in extreme cases. It's not usually very common. Doesn't. Okay. Are there further questions? So if we don't have other questions, I'll just summarize, by first of all thanking pharmacist Karim for that wonderful presentation and answering the questions very well. So we're very proud of you. Thank you very much. Then what we should take away from this seminar tonight is this: when a patient or a friend or any person presents to you, someone has always said, how can I have dry eyes and I'm producing tears, I'm tearing? It means that I have I don't have dry eyes. Is a paradox. The truth is that when there is ocular surface disorder, and then the tears are meant to lubricate the ocular surface, the eye very well. The cornea, the front of the eye is meant to lubricate. And then when there's an issue in the lacrimal gland process, in the tear process, of the tears lubricating the eyes, then dry eye disease is meant to occur. Is bound to occur. So once someone presents with says that I'm producing tears, how can I be tearing? The eye works just like the entire body works by homeostasis. The eye will want to will be stretching itself to make sure that the eye is preserved. At that that pressure, tension of trying to keep the eye, trying to struggle to produce tears. The tears produced is a reflex response. Is a response towards keeping the eye intact and safe. And then you see someone tearing, and that tear, if you should test that tear film, is not standard. The tear breakup time can be very low, and then the quality of the tear film produced is very low, and then you may not even have enough tear proteins in that tear film, so that you're producing tears, that someone is having dry eye and is producing tears, and the tear is tearing, doesn't mean that the person is the person's tear is healthy. It's not healthy. So it's a response by the eye to preserve the eye from the harsh environment that is being exposed to by not having enough tears to lubricate the eyes. So when someone presents to you with a tearing, with itchy eye, with a gritty feeling in the eye, with a red eye, with a burning sensation in the eye, just suspect dry eye disease. Then try to remove the triggers. Once the triggers are removed and it still persists, let the person use an artificial tear. It could be any of the artificial tears, ranging from solutions to emulsions to gels to ointments that are there. They've been proven to be very good in managing dry eye disease. When it still persists, and then people that have some connective tissue diseases like rheumatoid arthritis, they have a high tendency of being predisposed to dry eye disease or having it. So such people, it's good to also manage their their condition very well, and then you find out you struggle less with managing their dry eye problem. So the triggers should be handled very well. And when they're handled, then the tear substitute will have less work to do to manage the dry eye very well. So first, then thirdly, when someone presents with a red eye, please, as a pharmacist, don't prescribe steroid. We have been making that mistakes a lot. Don't prescribe steroids. Always try to ask questions, because red eye is multifactorial. Find out what could be the cause of the red eye. Where you are not sure of what is causing the red eye, refer. Then when you are sure of what is causing it, treat that, the red eye, and then don't go back to steroid. Steroid has to be only on prescription, and the patient has to be monitored. And steroids are usually is done with steroids. You have to taper the ophthalmic preparation, the topical agent, until the patient is off that medication, and then try to know the patient's ophthalmic history. If the patient is a known glaucoma patient, you need to be very careful in handling the patient's medications. If the patient is being known to be a glaucoma patient and is having a dry eye, it's good to add an artificial tears. It will help them, because most times anti-glaucoma drugs have that preservative called back that can cause the dry eye disease in people that are on them. So when you now prescribe an artificial tear, it helps them. So ask many questions, ask and ask and ask again. By the time you now ask questions on different issues of the patient's medical history, it will help you to now narrow and be able to give the right ophthalmic preparation that the patient needs. Then people that have allergy, make sure that it's only, it's not caused by dry eye, because allergic conjunctivitis can lead to eye itching, very comforting eye itching. So in that case, treat with anti-allergics. Then you can also introduce dry eye a tear, and artificial tears, to help the discomfort of the itching eye condition. Then let the patient be advised to use glasses that can preserve moisture, or stay away from harsh environment, dry environments, like staying in AC for too long, for hours, staying in the fan for hours. It can also worsen dry eye disease. Then lastly, when all has failed, definitely when you're managing a patient for that dry eye disease, please always work with side by side with an ophthalmologist. When all has failed, that patient can go for surgery, can go for have what you call pontal occlusion, or use pontal plugs. That's like the last, the last resort, where the patient has to use those pontal plugs to prevent further evaporation of the tears from the eyes. That's the basic. I think that's the basic things we need to know. At least our takeaways this night, on dry eye disease and its management. I don't know whether I've summarized well.
But somebody just added a point, which is in children, it's advisable to use tear substitutes that are preservative free due to its effects on cornea. I think I agree with that. Where possible, where possible, because like we said, price is an issue, but they are definitely a fantastic option for artificial tears. Yeah. And Dr. Madu has his hand raised.
Okay, is he in the platform? Let me check.
He's raising his hand.
Okay, is Dr. Madu in the platform?
Yes, he is. He's raising his hand.
Okay, please, at this juncture, let's welcome. Good evening, sir.
Good evening, my sister. Good evening, everyone.
Good evening, sir.
Yes. Please, am I audible enough?
Yes. President. Yes, sir. Sir, you have the floor.
Okay. Thank you very much. I am happy. I think I'm one of the last, or one of those speaking last. I know you want to round up, so that's why I have to raise up my hand. I joined a little Sorry, can you still hear me? A call
Yes,
is trying to
yes.
interrupt me. Can you still
Yeah,
hear me?
Loud
Okay,
and
yes, I
hear you,
joined a
yes.
little bit late. Okay, thank you very
Mm.
much. But I want to thank the presenter, I think Pharmacist Adeniji Karim, and I want to thank Ophthalmology Pharmacists of Nigeria. I just want to plead with the attendees to this meeting this night to try, for those who have picked interest in ophthalmology or this lecture, those who may want to be part of Ophthalmology Pharmacists of Nigeria, to contact the moderator, who is also the desk officer, so that they can join the specialty group. I don't know if Pharmacist Karim is a member of Ophthalmology Pharmacists of Nigeria, or he's just a guest lecturer.
Yes,
So,
yes, I am.
Okay, thank God.
He's a
Okay,
bona fide member.
all right.
A
So
card
thank
carrying
you
member.
very much. Thank you very much for your membership. I was very happy when I was reading your profile, having working with a lot of pharmaceutical companies and the rest on ophthalmic preparations and ophthalmological preparations, as well as with ophthalmologists and optometrists. So I was so happy. Please, incidentally, the ophthalmology specialty is the first medical specialty ever to be created in this world around the year 1900. In ophthalmology pharmacy itself is just somehow developing. And the ophthalmology pharmacists of Nigeria, by the time we were taking a kind of census last year or early this year, we discovered that the number of members were very few. And we really want to help this specialty group to build. Around the world, it is a developing specialty of ophthalmology pharmacy. So please, I want members to seize this opportunity. Those who have picked interest, myself, I've learned so much this night, especially about red eyes and the rest of it. You can, when you listen to both the moderator and presenter, you think that you are listening to professors of ophthalmology pharmacy. And I know everyone may want to be part of that. Of course, we can all specialize in ophthalmology, but those who do not have a specialty group in CPAN or who may want to join can please join to support them so that we can together grow this specialty group in Nigeria. Other African countries are already meeting us and they are borrowing a leaf from us. Together we can achieve more. Once again, thank you very much for your time in listening to me. God bless.
Thank you, sir.
Thank you very much, Mr. Our National Chairman. We appreciate your presence and then your contribution. We are grateful. Thank you, sir. Okay, I guess we have come to the end of tonight's presentation. In the absence of any other question or contribution, I want to call on pharmacist Dr. Bilikisu to give us the closing prayer. Pharmacist Bilikisu, you have the floor.
We thank God Almighty for making it possible to come to the end of today's CPAN clinical meeting presentation by Open. We thank our President, Chairman CPAN, Dr. Joseph Madu. We thank the presenter, Pharmacist Adeniji Karim. We thank our Open Desk 1 officer, Dr. Chinelo Chukwu. We thank the presenter for imparting knowledge, especially ophthalmic knowledge, into us tonight. And we hope that we at Open will continue to grow in strength. By the virtues of his mercies, we pray that God Almighty continue to increase us in knowledge and in wisdom, and We pray that CFAN will continue to grow in strength. Thank you, everyone, for making it a day with open tonight. Good night.
Thank you very
All right.
Thank you very much. Please, I've sent my number on the platform in case you want to join or you know someone that will want to be interested or would like to join. The number is on the platform on the chat group, the chat box. Thank you.
All right. Good night, everybody.
Good night. Pharmacist Karim, thank you.
Good night.
Good night.